Hello to everyone joining us on Zoom for this webinar. It is 7 p.m. Singapore time on the 8th of July, and on behalf of the Sing Health Duke NUS Global Health Institute, I am delighted to welcome all of you to part 2 of our 5-part webinar series. Today's session will be about examining maternal and child health inequities and how the COVID-19 outbreak has and is further expected to impact existing health inequities. The panelists will explore how the COVID-19 outbreak may alter specific health services which affect maternal and newborn care. They will also discuss the long-term effects of COVID-19 on maternal and child health programs and offer some potential strategies to mitigate the negative impact. Our moderator today is Professor Courtney Davis, who is the Education Core Co-Lead for the Sing Health Duke NUS Global Health Institute, Adjunct Assistant Professor at Duke NUS, and a staff physician in the Adolescent Medicine Service at KK Hospital. She has a clinical focus in adolescent medicine, including restrictive eating disorders, obesity, and adolescent risk-taking behavior. Her current research explores methods to improve medical students' communication skills with adolescents, the impact of participation in international service learning experiences on students' medical education, and eating disorders in Singaporean adolescents. I look forward to the discussions, and I'll hand it over to you now, Courtney.
Thanks, Marielle. Welcome. I'm delighted to be your moderator tonight for the second in a series of webinars sponsored by SDGHI. Maternal and child health advocates worldwide are concerned about the effects of COVID-19 on the health outcomes and health inequities in maternal and child health. The impact of COVID-19 on health inequities in maternal and child health extend beyond the direct impact of the virus to disruption and decreased access to other essential health services, as well as the potential effects of economic downturns on household health, nutrition, and available government services. As Marielle said, we will try to examine these issues and how they are playing out in the ASEAN region this evening. First, we will provide an overview of maternal and child health inequities in the ASEAN region and the expected impacts on COVID-19 on health outcomes, including maternal and child mortality. Second, we will look specifically at how COVID-19 is impacting specific essential maternal and child health services, such as vaccinations and access to maternal and newborn care. Next, we will also examine how the negative economic consequences of COVID-19 may impact the health of women and children. And finally, we will discuss what will be the long-term impacts and what are some potential measures that countries in our region can take to decrease the impact of COVID-19 on maternal and child health. We are very fortunate to have 5 preeminent experts on maternal and child health in the ASEAN region to be joining us today. I'm just going to take a minute to introduce them and then we will begin the discussion. First, we have Mr. Bjorn Andersen, who is the Regional Director for the United Nations Population Fund in Bangkok. He joined the Asia Pacific Regional Office of the United Nations Population Fund as its director in 2017. Mr. Andersen has over 3 decades of extensive experience in international development cooperation and has held key positions in program management, policy development, strategic organizational management in both the UN system as well as other government agencies. Next, we have Ms. Mariam Khan. She works as the representative for the Lao PDR for the United Nations Population Fund. Ms. Khan has over 20 years of diverse experience in leading and managing development programs, humanitarian response, change management initiatives, and working with multicultural teams. She brings a passion for promoting a rights-based agenda that focuses on improving the lives of women and young people in particular through culturally sensitive approaches and evidence-based methodologies. She has also worked in Algeria, China, and Pakistan in significant global health capacities. Dr. Paul Pranik is joining us. He is the chief of the Childhood Survival and Development Program for UNICEF Indonesia. He is a physician and a global health specialist with over 20 years of experience in low and middle income countries. This includes having led 2 large cross-sectional university-based research and evaluation programs and senior management positions at the global and country level for UNICEF. His program experience, research interests, and published work focus on a range of issues, including health system strengthening, evaluation methodology, and health informatics, maternal and child health, nutrition, communicable disease control, gender-based violence, social capital, and public health ethics. We also have Dr. Catherine Ann Reyes, who is an assistant professor and associate dean for research in the Department of Health Policy and Administration, the College of Public Health from the University of Philippines, Manila. Dr. Reyes is a trained physician, health policy analyst, researcher, and educator. She is actively contributing to the development and implementation of health reforms, primarily in the Philippines. She focuses her policy analysis and research work to enable decision makers and managers to make better decisions towards stronger public health systems, health financing, institutional governance, and regulation. Her practical experience also spans program-specific interventions, such as in maternal and child health and health emergency management. Finally, we also have Dr. Maria Asuncion Silvestre joining us. She is the president of an NGO called the Health of Mother and Child, and she is trained in neonatal and perinatal medicine. She has made key contributions to national policies in the Philippines on maternal and newborn health and nutrition. She has also provided technical assistance to the Philippines Department of Health in the development of an evidence-based essential intrapartum and newborn care protocol, a simple life-saving package of interventions known now as the First Embrace across the WHO's Western Pacific region. She founded a nonprofit, KMI, also called the Health of Mother and Child, dedicated to protecting the health of mother-child dyads, which has contributed significantly to healthcare system improvement. She is also a member of the Asia Pacific Center for Evidence-Based Healthcare. So we're very lucky to have people with such a wealth and range of experience joining us tonight. So if I could ask Mr. Anderson to please start for us.
Thank you so much, Courtney, and good evening, everyone. I am so pleased to have been invited to participate in this important discussion on analyzing the impact of COVID-19 on maternal and child health in the ASEAN region. For those of you who may not know UNFPA, it is the United Nations Sexual and Reproductive Health Agency, and our mission is to deliver a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. In the Asia Pacific region, we work in 22 countries in Asia and 14 countries and territories in the Pacific to accelerate action to achieve the Sustainable Development Goals and the UNFPA strategic plan's transformative results, which are to eliminate preventable maternal deaths, eliminate the unmet need for family planning, and eliminate gender-based violence and harmful practices. Specifically in the area of maternal health, we work in development and humanitarian settings to promote universal access to reproductive health care for women and young people, quality health services for all pregnant women, reliable access to modern contraceptives and rights-based counseling and service provision, and training of health workers, in particular midwives, to ensure a safe and dignified birth for every woman with a skilled attendant. Our work is guided by the Program of Action of the International Conference on Population and Development of 1994 and grounded in the principles of human rights and gender equality. The ICPD Program of Action 25 years ago established a new comprehensive concept of reproductive health, including family planning, maternal health, and sexual health, affirming that women have the right to make decisions over their own bodies and if, when, and with whom to have children, as well as the number, timing, and spacing of them. The program of action affirmed that ensuring universal access to sexual and reproductive health and rights not only benefits the individual, but also communities and societies. Now, 25 years later, it is clear that sexual and reproductive health and rights saves lives, advances gender equality, improves health and well-being, enables women to access quality education, and find and retain decent work. It also increases productivity and household income, improves children's health and well-being, and is fundamental to achieving sustainable development. However, the achieving of sexual and reproductive health and rights remains an unfinished business. In the Asia-Pacific region broadly, 10 women die every hour in pregnancy and childbirth. For ASEAN countries, there has been a lot of progress, but statistics often hide underlying inequalities that often hinder women's access to sexual and reproductive health services. Women living in geographically remote locations, those from poorer socioeconomic groups, women from ethnic minorities, and those women who are least educated are at an even higher risk of maternal morbidity and mortality. With the ongoing COVID-19 pandemic, many of the challenges faced by women, especially for the most marginalized women, are being exacerbated. As we have seen from other health crises, there have been significant disruptions to sexual and reproductive health services provision. In the Asia-Pacific region, broadly speaking, as well as for the ASEAN countries, we have seen that in the rush to prepare for and respond to an increase in patients with moderate to severe COVID-19 symptoms, there have been huge challenges to ensure the continuity of sexual, reproductive, maternal, newborn, and adolescent health services, which are essential and life-saving. In addition, there have been changes in patterns of health-seeking behaviors of pregnant women who are now fearful to leave their homes and come into contact with potentially COVID-19 positive persons in health facilities. This change in care-seeking behavior is one of the greatest concerns for UNFPA. Not only has the pandemic jeopardized the many years of effort to encourage women to seek care during the pregnancy and have a safe delivery in an institution that is fully equipped with life-saving medication and skilled birth attendants. This change in behavior can have devastating immediate consequences. It means that healthcare professionals are not able to quickly detect and respond to complications related to women with high-risk pregnancies and danger signs for the mother and fetus. UNFPA has performed modeling to estimate the impact of COVID-19 on maternal health outcomes, including maternal mortality and access to family planning. The analysis shows that if the lockdowns continue and individuals are not able to access family planning and maternal health services, unintended pregnancies will increase as well as preventable maternal deaths. And this is unacceptable. As the COVID-19 pandemic continues to unfold, we need to ensure that governments and policymakers are held accountable for ensuring the continuity of sexual and reproductive health care services throughout the pandemic. We must ensure that even during times of crisis, women do not only survive childbirth through ending preventable deaths, but also that they are able to thrive by ensuring universal access to sexual and reproductive health, information and services, including financial risk protection. But most importantly, we need to work together for societal change to ensure that the lives of women and girls are valued equally with the lives of men and boys. We must push back against the growing trends of conservatism that threatens women's health within the ASEAN region and beyond. The health of women should never be compromised or undermined. While COVID-19 is presenting many challenges to maternal health in the ASEAN countries and around the world, let us learn from this crisis. Let us work together in partnership with governments, the United Nations, civil society, academia, and most importantly, healthcare workers, to once and for all transform our existing health systems and expand the enabling environments for women and girls to realize their sexual and reproductive health and rights. Thank you so much for inviting me, and over back to you, Courtney.
Thank you so much, Mr. Anderson, for such a good overview of everything that is happening currently in the ASEAN region, as well as explaining the impact broadly of COVID-19. Now we'll have Ms. Khan speak a little bit more regarding her work in Laos.
Thank you, Courtney, and thank you, Bjorn. Since colleagues, Bjorn has shared already. Can you see my screen or not yet?
Yes, we can.
All right, great. Since Bjorn has already spoken about what UNFPA does and how we tackled it at the regional level, allow me to focus a bit on the Laos context and how we operationalized some of the very important items that Bjorn spoke about. So in order to save and protect women's maternal health and sexual reproductive health and rights, it's important to know who those women are, where they are, how many there are. In Laos, there's about 3.6 million women and girls. We've got the highest adolescent pregnancy rate in the ASEAN region. And a few factors that influence how women will be impacted during the time of COVID include the fact that women are predominantly working in the informal sector. The burden of housework, care increased tremendously. The baseline was already it being 4 times more than that of men. Women are involved in economic activity pretty much on parity with men here, but predominantly in the informal sector. What is very interesting is that almost 70% of the health workforce, if you look at doctors, nurses, and midwives, is female. So what did this mean in terms of, what does this mean in terms of, I'm trying to move to my next screen, there we go. Trying to protect their maternal and child health care. The data that I've shown you, it's at the national level, and it is much worse for women who are living in areas without roads, rural women, women with less education and less incomes. Together with other partners, we did an analysis of geospatial mapping to see vulnerabilities, and we also looked at the health data. Quickly, it was evident that the 2020 data was much lower in terms of antenatal care compared to the past 3 years. We also saw that the deliveries at health facilities for the first quarter of this year reduced significantly from 27,000 the year before to 25,000 this year. All of this, of course, meant that access to care was becoming less. Now you're seeing the data on family planning usage. And the column where my cursor is, the shortest column, is the uptake of family planning services. I mention this because family planning has a direct impact on maternal and child health and maternal mortality. Looking at the scenario specific to Laos, we worked with the government and also Bjorn's team to consider what would be the impact in Laos, and we looked at 30% reduction in care and up to 50% this year, including some impact for next year. So we came out with some statistics on the numbers of unplanned pregnancies that are likely to be coming up. The section in blue is the number of unplanned pregnancies anyway, because of the very high unmet need. 15 out of every 100 women who wish to plan births in Laos currently are not able to do so because of lack of access or knowledge or services. The box in yellow you will see is the addition caused by COVID of unintended pregnancies. This one, the lower block, is the best case scenario, and the higher block is the worst case scenario. In terms of maternal deaths, again, the blue number, 284 maternal deaths can be expected, sadly, on an annual basis in Laos. And this number would increase by an additional 262 in the best case scenario and up to 400 in the worst case scenario. So with this doom and gloom, what did we do? Well, working closely within the UN system and other health partners and the governments, we immediately did communication around family planning and ensuring access to healthcare, that it is not interrupted. There was a lot of misinformation. Women in rural communities who forage for food, where anemia is already high, weren't even going out to collect food. So they was having impact in further malnutrition and other things. So communication was the #1 item that we focused on, and gearing it to different entities, making sure that it was in ethnic languages, that the young people were having information and messaging appropriate to them. Provision of PPE for midwives, especially in a country that's almost 70% rural, where the bulk of the women live in rural areas, are involved in agriculture. Community-based services are extremely important, and midwives play a critical role. Youth-friendly services for young boys as well as young girls to make sure, recognizing the very high teenage pregnancy rates, that they would still access. We scaled up hotlines, made them 24/7. We also made sure that infection prevention control messaging with other partners kept going on very strongly. Psychosocial support was provided, not just in general for young people, for survivors of violence, but also for midwives who themselves were working tremendously longer hours. And we made sure that messaging on breastfeeding, the need to continue in Laos, 4 out of 10 women will not nurse exclusively for the first 6 months. These were all immediate response elements that we delivered together with the Ministry of Health and others. As we move into the next phase of COVID, because Laos has been very fortunate, there were 19 cases. The borders have been closed for almost 3 months now, and we haven't had a new case in 2 months, more than 2 months. And we want to keep it this way. But the fear, misinformation, and changed practices are really on track to influence the progress made on reducing maternal mortality. And general service quality, whether it's for youth-friendly sexual reproductive health, whether it's for services about women who are facing domestic abuse, all of these factors contribute to increased danger for maternal well-being and safe deliveries. And then there's medium-term lessons that we're also looking at. But I think 2 important things that I do want to speak to is about the integration of maternal health into broader communication, community-based interventions, and the need to engage men and boys in an environment such as Laos, using every possible mean, be it radio, be it television, be it mobile clinics that go out and mobile teams. And in an environment like Laos, even the loudspeakers that are done from the community village workers outpost or help. So every single message that could be used to communicate what is available, how to gain support or access services was deployed. And collaboratively, so that people were not getting multiple messaging, but that they were getting simple messaging that was useful and relevant and they could act on. Connected to the teenage pregnancy and the high school dropout rates, because schools were already closed, in parallel, we started efforts to make sure that teenage girls would not drop out of school, and messaging along retention of teenage girls in secondary schools was also maintained. All of this recognizing that the immediate as well as midterm things cannot be sequential, but a lot of this has to go parallel. So if I was to sum up 3 key things, it would be around ensuring that health service providers were safe and enabled to provide continuity of care. It was to make sure that communication could be as simple but consistent as possible and delivered through as many sources as was possible, and making sure that different constituents who needed information around maternal health care, pregnant women themselves, women who were breastfeeding, women who needed to deliver, women who didn't even know they were possibly pregnant at this stage, younger women, were all getting messaging through sources that was convenient to them. So I can't say that we reached 100% coverage, but we certainly thought about the best ways to do, and it's work in progress. Whenever a crisis hits, it's new challenges, new problems. But lessons from the Ebola crisis in West Africa were some of the elements that UNFPA built on as we considered the response to the COVID-19 scenarios. I'll stop here. I don't know if I've run out of my time, but I'll be happy to address questions later. So thank you. I hope this will give you some food for thought. And Courtney, back to you.
Thank you so much, Miriam, for discussing the aspects to the very comprehensive and cohesive response to the COVID-19 situation you've had in Lao PDR. Now, Dr. Pranik, would you share with us your thoughts on the situation?
Great, thank you. Technical problems as usual. Thanks everybody. Really good to be here with you today. I'm going to spend a few minutes talking about what's happening here in Indonesia on the ground around COVID, with a real focus on what's happening with child health services. I think a lot of the messages that are coming through are very similar to what Miriam shared around reductions in service delivery, but I'll try and show you some data from Indonesia. First, we have the dubious distinction of having the highest number of COVID cases in the ASEAN region. It's only about 2 or 3 weeks ago where Indonesia passed Singapore with its sort of 5 or so million people compared to our sort of 270 million people. What's important to underscore is that with COVID, 80% of cases we think are asymptomatic and may never be detected. And if you test more, you're going to find more, right? So this graph basically looks at testing per the x-axis is testing per cases per million population, and the y-axis is testing per million population. And basically, yeah, so Singapore is finding lots of cases, but they're doing lots of testing. Indonesia's very close to the bottom, but others is Laos, Cambodia, Vietnam, etc., where testing rates are also very low. So given how infectious COVID is and how quickly it's moved around the globe, the assumption is that the reported number of cases are just a fraction of the true number of sick COVID-infected individuals, which is just a tiny fraction of the overall number of infections in the population. Well, COVID we're still learning so much about it, but what we do know is that children do not seem to suffer seriously from the direct effect of COVID. So there's fewer infections amongst children relative to other age groups in the population. This just shows you data on the left from Italy and Indonesia, showing 1.2% under 18 in Italy, and around sort of 7% or 8% under 18 in Indonesia, which is more a reflection of changes in the differences in the population structure. So lots of older folks in Italy, lots more younger folks in Indonesia. But proportionally, it's quite a small number. We also know that children who are infected tend to get sick less often. So amongst a large number of kids that have been examined in other countries globally, only 5% or so of those that present to hospital are going to be serious, less than 1% critical. And most of those who die actually die from other causes, not from COVID. So they'll have some sort of comorbidity. So they're kids that are sick otherwise. We have no idea why this is the case. So I hope nobody asks me because I can't answer. But children's immune systems are just very different than adults for a range of reasons that I can't get into in 10 minutes, but that probably has something to do with it. The other thing that we do know is that children tend to transmit less, so they definitely get infected. And we do have what are called antibody or serology studies from around the world that are starting to show, that children are definitely infected, not at the same levels that they are that adults are proportionately. But we also know that while they get infected slightly less often, they also transmit less often as well. So if you go to a church or a conference with a bunch of adults, you'll have super spreader events and lots of people getting infected, but you'll have infected kids sitting in classrooms with high level of exposure to other children, and the other children don't seem to be getting infected. So they seem to be less symptomatic and less transmissible with fewer secondary cases for children, which has got important implications around things like school closure and so forth. So the direct effects on children are definitely less than adults as far as we know. Now, to talk about the important Indonesia, what I really want to get into is issues around the indirect effects, which is kind of similar to the points Miriam was making. So Indonesia's healthcare system is organized around kind of two pillars. One is the primary healthcare facility, which is known as a puskesmas. And then there's a network of village health posts around the country, which are voluntary, run by community health workers, tens of thousands of them. And those are called posyandu's. So we've done research looking at service delivery gaps at both of these levels. And what we've seen basically is that at the primary care level, about 8% of them have very serious service disruptions. The worst affected, believe it or not, is safe delivery, so just similar to what Miriam has just said around the Laos experience, but also affected are family planning, immunization, antenatal care, and PMTCT, so prevention of mother-to-child transmission. In Indonesia, the big problem is the closure of village health posts. Figures vary, but between 70 and 80% of them are suspended. And this is data that comes from, this survey was done on 1,386 primary healthcare facilities, which is about 15% of the total number of facilities in the country that we were able to survey with sort of mobile platforms. And what you see at the village health posts, they deliver a limited number of services: growth monitoring, immunization, importantly, antenatal care, and vitamin A injections. But the effects on immunization are very dramatic. So we did a follow-up survey in June. And by the way, we had our lockdown recommendations in March. So this survey was conducted around 6 weeks after that. This other one was conducted about 8 weeks after that. And this one, we covered 5,000 or so facilities in the country. That would be a single primary healthcare facility with the range of different village health posts that facility supports. And 5,000 facilities is about half of the facilities in the country. It's a nationwide mobile survey. And what we found looking at immunization during a deeper dive is about 84% of facilities documented some sort of service suspension. In 64% of cases, there was closure of village health posts, which is a really big deal. And when you try to unpack why and what are the drivers of that, what we found is that there's what's called hesitancy, so a reluctance of communities to come to these village health posts because honestly, they're a bit anarchic, a little chaotic. 50 kids, 100 kids all coming for their immunization sort of on the one morning a month that village health post is open. And I think the communities perceive that as kind of an unsafe environment. So there's definitely hesitancy there. But there's also supply side issues where there's not really protective equipment. We think about protective equipment as something for hospital nurses and doctors, but we don't think about it as something that a community health worker is going to need. So there's definitely limitations there. There's fear amongst health providers themselves about getting too close to patients and vaccinating children. We have staff that are pulled away from immunization to manage COVID. We have supply chain interruptions in vaccines. So we have major stockouts in many places in the country. And we also have a redirection of funding away from kind of core maternal newborn child health services towards COVID-related activities. So how does all of this translate into coverage reductions? So what we've seen, again, in Indonesia, are recommendations around physical distancing were implemented in March. They were not enforced. And a lot of that is because folks are so poor and so reliant on informal sector work that there was a real fear by political leaders about the negative impacts that this would have on poor families and households. So things weren't enforced. There was less movement, but not a massive reduction. But because of these closures of the village health posts and the reductions of services at the primary healthcare center, we've seen over the last 2 months about a 35% reduction in immunization coverage. What does that mean in practice? Well, in Indonesia, your DPT3 coverage is only around sort of 80%, measles only 80%, full immunization coverage is only 60%, right? Baseline, that's before COVID. So that additional reduction in 35% is extremely serious, and it's going to have major consequences for children. So just to summarize, I don't want to get into too much detail, but basically, our feeling is that COVID is having much more modest and limited direct effects on children, but the indirect effects are likely to be severe and sustained. Models predict about a 10 to 45% increase in child mortality amongst low and middle income countries. What we find is that all services are not equally affected. The ones that are delivered close to the community through village health posts like nutrition, antenatal care, immunization are the ones that are going to be the most seriously affected and affected the most early in the response. Outbreaks are all but a certainty. We've already heard, surveillance systems are also affected, but we know that there's already outbreaks of diphtheria taking place in a couple of provinces. We're very, very concerned about measles because of the high risk of fatality in particular. We're also concerned about other kinds of comorbidities such as acute malnutrition, because there's less income, less agricultural productivity, less market access. Acute malnutrition levels are expected to increase substantially, and acute malnutrition and undernutrition in general drives about half of child deaths. So we think that that's also going to be a major issue. And then we share similar concerns to the UNFPA folks around issues around declines in maternal newborn care as well as sick child care. And what does that mean for children suffering from diarrhea and pneumonia and mothers that are trying to deliver their baby safely? So the new normal is going to be critically important. We need to have new guidance, positive examples, good communication messages to really try and get services back up and running so that we don't see an epidemic of child mortality, not from COVID, but from COVID's indirect effects. I think I'm going to stop there. Those are the key messages, but real pleasure doing with you. Thanks.
Thank you so much, Paul, for that very interesting presentation. And thank you so much for highlighting the indirect effects of COVID and the need for us to establish a new normal that's gonna allow us to provide healthcare. Next, we'll hear from Dr. Reyes, who will speak a little bit about her work in the Philippines. Thank you.
All right. Good evening, everyone. I'm happy to join the panel tonight to share our experience in the Philippines, and I will be speaking together with my colleague later on, Dr. Mian Silvestre, who will be focusing on the clinical implications of COVID-19. So I'll be speaking more on the systems perspective and how this has overall impact on our maternal health service. So I'd like to begin with the with a finding that even before COVID-19, Philippines has been struggling in reducing its maternal mortality ratio. We are still far off from our trajectory to reach our SDG target. So we've been really having difficulty addressing that. Compared, for instance, on our under 5 mortality as well as infant and neonatal mortality, where we are doing a better job compared to maternal mortality. And we have to appreciate, of course, that it's reducing maternal death is really a complex process, beginning from ensuring that a woman will have control over her decision for her reproductive health, and whenever she decides to get pregnant, she receives adequate antenatal care, also delivery care, as well as postpartum care. And we know, of course, that for that to happen, resources as well as processes have to be in place so that she is well taken care of. And in the Philippines, one of the, there are several reasons why we are not able to do this even before the pandemic. And one of the things that I'd like to focus on, because our topic is on equity, is our is our performance in terms of ensuring financial risk protection. This is very important because a woman should be able to access healthcare whenever she needs it, and without fear of financial catastrophe. Even before the pandemic, we see that women of reproductive age have different levels of financial coverage. In the Philippines, you have a maternity care package where it sends a signal to any woman that if you're pregnant, you can expect to be taken care of in facilities and expect quality care. However, we can see in our 2017 data that even before COVID-19, the spread of support actually is not equal. So the lower income women have lesser financial coverage. You can imagine that she's already financially disadvantaged on top of the expectation that she will have poorer nutritional status and even poorer overall well-being. And this is also reflected in terms of how she accesses healthcare. Women who are in the lower income status have lesser access to skilled birth attended delivery. And this is very important because access to skilled birth attended delivery has a very important contribution to the overall outcome of maternal health. And this is likewise reflected in the number of deaths happening in live births, among the live births. And we see that most of the deaths are actually seen among the lower income women. So we see that even before the COVID-19 status, that we already see a level of inequity in terms of encouraging women to seek care timely care for her and for her baby. And prior to COVID-19 last year, that the Philippines signed into law the Universal Healthcare Law, which is supposed to address this inequity. And the Universal Healthcare Law was a signal that all Filipinos, of course including women, will all be members of PhilHealth, our national health insurance program, and all of them should have access to healthcare, maternal care, for instance, when they need it at any point in time. However, due to COVID-19, a lot of the activities that are prepared to roll out universal healthcare has been interrupted. And this resulted to threats in terms of providing financial protection for women of reproductive age, for pregnant women who are seeking antenatal care, as well as for those who have recently given birth and will need to bring their children to primary health care center. So we have seen that as same reflection with Indonesia, that the pathway towards primary care actually has been COVIDized, so to speak. There were different messaging and hesitancy for women to seek reproductive health, antenatal care, as well as primary care. And this has also been experienced moving up to the higher level of care. Delivery is not as usual. Now, we've seen announcements as well as a clarification that all deliveries will be done in a different ways. There's of course PPE involved to make sure that skilled birth attendant professional as well as the mothers are well protected. And this has, of course, changed the dynamic of delivery care. And we've also seen reports wherein even blood supply has diminished. And we understand, of course, that for maternal care, especially during delivery, this is a very critical situation because any delivery can immediately turn into an emergency, and blood supply is of course very critical. So I'd just like to share very briefly some of the accounts that we've seen and reports from our government that especially during the lockdown, UNFPA in the Philippines actually reported almost 50% reduction in seeking reproductive or family planning services, and they projected that this will result to around 2 million pregnancy in the coming months, and around 10% of that will be pregnancy among women less than 20 years old. So that's a lot of things to absorb, given that there is already at the moment a high level of increasing number of unwanted pregnancy in some segments of the population. We have also seen accounts of difficulty for women to access healthcare in a timely manner, and we know this is very critical during delivery because there are some confusion in terms of how referral will be done in a safe manner. And this has created some confusion in terms of transferring patients and ensuring that they are able to deliver safely. And my final point is that because of the changes in the delivery of care, it has also been communicated, for instance, that the cost of delivery will increase. And this has, of course, sent worries to women, because currently the coverage that is given through PhilHealth may not even be enough to cover for the increased cost primarily because of the PPE, to cover for the PPE. So my last word will be, in all of this, we need to recognize that maternal health is still important even in the midst of COVID-19. And to address this, we need to go back to really ensuring that we restore primary care services and make sure that it is safe, again, for women to consult in a timely manner in their primary care provider. There was also discussions around the effect of using a lot of funds to fight off COVID-19, and this may threaten the implementation of universal health care. But of course, our call is for this not to happen, that we still implement UHC, because it's very important that equally critical services like maternal health, among others, will continue to be provided even with the COVID-19 pandemic. So I'll stop there and I'll turn you over to Dr. Mian Silvestre.
Thank you so much. Are you ready to start, Dr. Silvestre?
Yes, I am. Let me share. Good evening. Good evening. Thank you, Kathy. I'd like to present a joint presentation by Dr. Romile Alfonso, my colleague, and myself. This is a brief presentation on how civil society contributed to the COVID-19 response in the Philippines by applying an equity lens to what are called clinical practice guidelines for intrapartum and newborn care. Okay, why focus on the newborn in this presentation? These graphs here show that almost 1/2 of all under 5 child deaths occur in the newborn period. And because of that, and the stagnation in newborn mortality reduction, the dramatic decrease in under 5 deaths witnessed over the first 2 decades here in the line graph has been blunted by the fact that the newborn mortality rate reduction has become stagnant. When do newborns die? As in many other countries in the world, 3 out of 4 newborn deaths occur in the first week of life, more so in the first 2 days of life, which point us to the fact that we need to improve labor delivery practices, because this labor delivery and immediate newborn care period constitute a unique window for caring for the dyad, the mother and newborn dyad, under the care of multiple decision makers, actually. The higher the level of facility, the more decision makers become involved in the negotiations and the coordination. In the Philippines, back in 2008, we instituted basically a standard package of practices that are simple, cost-effective, and evidence-based, and implementable for all healthy newborns, but also practices extending to the care of sick, preterm, and infants born by cesarean section. This In the immediate newborn period, we re-choreographed basically the actions taken by health workers in the first few minutes to the first few hours after birth to entail a time-bound sequence of actions. We called these actions for the newborn the 4 core steps of essential newborn care. First, immediate and thorough drying. Second, early skin-to-skin contact. Only then is the cord clamped to allow the placental transfusion of blood. And number 4, uninterrupted skin-to-skin contact, the baby not being separated from the mother to complete the first breastfeed. Other countries have taken on these standard care practices, now called early essential newborn care, or ENC, the social marketing handle being the first embrace. Da Nang Hospital in central Vietnam demonstrated the protective benefits of implementation of even just these 4 core steps. Clinical outcomes consisting of decreased sepsis incidence, decreased admission to the neonatal ICUs, increased exclusive breastfeeding in the NICU babies, and increased stability so that they could practice kangaroo mother care, were some of the clinical outcomes that were demonstrated and attributable to the change in immediate newborn care practices. In contrast to the evidence supporting non-separation, we do not have evidence to support that early separation of the mother-newborn dyad in the COVID-19 context does actually prevent infection of the baby from its mother. Unfortunately, it creates a greater concern that compromises the mother and baby's well-being even in the long term. In one article by Alison Stube, she outlined that because of routine separations, we have twice the burden, twice the necessity for sets of caregivers, protective equipment, isolation rooms in the health facility or even at home, interference with skin-to-skin contact, disruption of breastfeeding initiation, and of course, the extreme duress on the mother in terms of stress and possibly even postpartum depression. What is the picture in the Philippines? Is estimated that in every 4 weeks, 142,000 newborns are delivered. Almost half of these births occur in community-based health facilities. And as such, the concern, the serious concern, especially of our United Nations agencies in the Philippines, was that this routine separation of newborns from their mothers would constitute an invalidation of standard practices that are already being implemented in our health facilities to prevent these early newborn deaths, to improve exclusive breastfeeding rates and all its protective benefits. In a survey of more than 700 healthcare professionals in maternal and newborn health, the Institute of Tropical Medicine in Antwerp found that the respondents reported a lack of practical guidance on how to decide on patients showing symptoms of COVID-19. In our early guidance issuances, understandably, because we were working with the unprecedented policy experience from countries earlier hit by COVID, we ran into such worrisome recommendations as these. For example, all mothers and newborns are suspect cases until proven otherwise. There were recommendations for routine separation into different isolation rooms until the test results for both mother and baby turn up negative. And or if testing kits were not available, that routine separation be maintained for 14 days from resolution of symptoms or exposure. So the operational implications were horrendous. Health workers had to be in full PPE because all mothers and newborns were suspect. and the enabling environment for these recommendations to be implementable were just not available. So timely RT-PCR testing capacity, especially in the early phases of the pandemic, was just not available especially in our lower level facilities and rural areas. The intent was good, of course. We did not have evidence to ensure that the newborn would not be infected by others. But the problem is the availability of isolation facilities, the inaccessibility of full PPEs, and the uncertainty surrounding whether alternate caretakers, whether in the home or in the health facility, would in fact be the ones to transmit COVID illness to the baby and not the mother. So plus the key assumption that feasible, sustainable alternative infant feeding options like formula powders, that was also a key assumption that under lockdowns especially was just not doable. So we knew that this COVID-19 required an agile response. And as civil society, what we tried to contribute to was volunteering to do, together with a pool of more than 50 clinical epidemiologists, rapid evidence reviews are being generated continuously, including rapid reviews on vertical transmission, transmission through breast milk, etc. So these living, updated, rapid recommendations should not, of course, if you think about the GRADE methodology for CPG development, should not bypass stakeholder consultations. And after these issuances are disseminated, there's a need for practical guidance in harmonized actions. We did acknowledge that technology could facilitate this quick, agile response. And that's why rapid evidence reviews were one of our CSO responses. The other CSO response that we contributed to was to collate expert guidelines into unified algorithms or decision trees that would help workers, especially in primary care facilities, to make valid decisions and not be trapped into decision points that they could not make decisions on. Features of these recommended guidelines and unified algorithms where we tried as much as possible to make the right thing, the easy thing to do in a simplified flow and format, in practical evidence-based guidance as the default standard of care. But for mothers who decided to opt out from the default standard of care, which is the first embrace, opt-out decisions could be made in a shared decision-making context. We wanted to de-emphasize the need for RT-PCR testing in the decision-making as to separate or reunite the separated dyads. And these were the reasons. Testing does not really change the clinical management in the immediate care, and the results, at least in the early stages, should not come in the way of sound clinical judgment, especially when the turnaround times for the results were taking so long. So shared decision-making was introduced into the unified guidelines. Here's a sample of the unified algorithms that we generated using standardized shapes to designate actions or decision points for the even primary healthcare workers in our lower level facilities. These are some of the issues that they needed to decide on in their shared decision making with mothers, to ask them, do they have alternate caregivers that could care for the baby separated, or are all the alternate caregivers in the family likewise exposed and or COVID positive? What is the feasibility of isolation in the facility and or in the home? And what were the alternative feeding options available? That way, it was not an imposed decision for routine separation, rather shared decision-making that was family-centered and woman-centered. So the key messages would be that health workers need practical guides for the COVID-19 response. Otherwise, the fear and uncertainty drive us to knee-jerk reactions, to separate, to distance ourselves from even the patients that we need to care for. There's a need to balance personal safety, well-being, provision of quality care, and of course, the mental health of both the patients, the families, and our health workers. Clinical practice guidelines do improve quality of care, but we would like to emphasize that stakeholder consultations are very important. Technology can facilitate CPG development, of course, dissemination, feedback, and the updates so that they are living documents. Thank you very much. I'd like to also thank the partners in civil society that worked on this response. Back to you, Courtney.
Thank you so much, Dr. Silvestre, for that great presentation about how you can create evidence-based guidelines and help improve care in such a dynamic sort of way. So we received questions before the presentations, and then we've also gotten a couple more questions in the chat. I'm very aware that we're almost out of time tonight, and actually a lot of the questions have been already addressed by the presenters. Amazing presentations. But one question, Paul, I was wondering if you wouldn't mind answering is, someone asked, in Indonesia, as shown with the decline in access to maternal and child health services, is there any plan or effort at this point in time to measure the impact long-term outcomes, such as kind of rates of malnutrition and such?
Yeah, thanks. Yeah, there's a couple good questions. I'll just do the ones that I can respond to anyway. So impact assessments are tough because you've got to go to homes, right? So it's tricky. If you got to start weighing and measuring children, it kind of puts people at risk. So I think there's a bit of, people are really cautious about wanting to do surveys. You can get routine reporting data, which gives you some measure of, access and availability, but impact, it's going to be tricky. And we're doing like remote surveys of people and stuff by phone, but it doesn't allow you to do a mid-upper arm circumference or to check for stunting. Mm-hmm. So it's quite tricky. We are definitely seeing the immunization related coverage declines. That's very clear. We're definitely seeing the outbreaks, but some of the other issues are more complex. There's another question that was quite important around, do children potentially asymptomatically transmit, all right, and COVID? And it's not clear is my answer. We still don't know. What's incredible about COVID is that, with the flu and other things, it's the symptomatic people that transmit. With COVID, we know that quite a number of infections happen in the pre-symptomatic people or by people that don't have symptoms, all right? So that's definitely the case for adults. There are certainly some cases in households where children are the index case, the first one in the household infected somehow, but that's a very tiny proportion, right? So I think it's possible, but it's probably not all that common. And then there was another question around access to the rapid assessment report, and I can send that to the organizers when they disseminate the slide decks. I'll attach that with mine. I think those are the main questions from my side.
Lovely. We did get a question beforehand, and I've seen kind of similar questions happening in the chat, which is people are wondering if the impact of COVID-19 on health outcomes or health access is different among more kind of rural populations or populations that are more kind of migrant or refugee populations, and kind of how do we better kind of address and support those communities. I'm wondering if any of the speakers have any comments on that. Marianne?
Yeah, thanks for raising this. I briefly touched upon the fact that for Laos, for example, we analyzed, we did a geospatial mapping because the infection was coming from the borders. So we analyzed where the border points were, where the migrants were most likely to be returning to. And because Laos is not a very densely populated country, the priority for communication and risk prevention was centered on where the largest number of returning migrants were going to be. Again, in a low income and low resource setting, it wasn't so much about testing, but a lot more about contact tracing. So knowing where the first few infections were and really managing that contact tracing and continuing to do that kept the testing costs down. And also recognizing that, in the beginning, tests weren't so much available. Yes, the impact is different for COVID infection. And in the beginning, depending on density, income, access, but then the socioeconomic fallout will mean that a different set of factors will influence vulnerabilities. Rural communities, poorer communities that have to walk to access care, that don't trust providers, where the primary healthcare providers aren't going to be themselves protected, will have a fallout in the longer term also.
Yeah, maybe just from my side to echo, there's like a golden rule in public health that in any outbreak, it affects initially a group that's biologically vulnerable and then settles out in a group that's socially vulnerable. And in my big worry with COVID is the urban slums, because there's zero ability for folks to protect themselves, right? And there's just, we have access to Facebook and Google data that's anonymized and aggregate, and we can look at population movements. And poor people just can't stay at home, right? It's impossible. And plus they're living in situations where you have 6 or 8 people in a single room, right? So, this is a very, very high transmission area, high transmission risk. We're starting to see some data from big cities like Mumbai saying things like 30% of some of the urban slum areas are COVID positive. We know that in the United States, there's a massive gradient by race amongst who's getting infected and who's getting sick. And that's going to pan out socioeconomically as well. I think rural areas are going to have it a bit easier in some respects because it's not, it's an airborne, it's a droplet transmission, lots of contacts. So there's going to be less transmission, but I think, it's still going to settle out in groups that are socially vulnerable.
And then just one final question that we received earlier today was, how would you recommend or how can you suggest that health administrators can monitor kind of real-time changes in coverage of reproductive and maternal and child health services in the current COVID-19 situation? Kathy, do you have any thoughts on this?
Right. So I think it's very important that we immediately utilize the existing information system that we have, however that crude may be in some settings. So because it's very important that we use what we already have, like no need to start a new way of collecting data. So that's very important to utilize the existing administrative mechanism for data collection. And we also mentioned actually in several instances already in this discussion, the importance of ensuring that primary care services is up and running, because in most systems there is a mechanism to collect this kind of information from the primary care setting, and that's also very important. Another opportunity I think also is that most of us has embraced telehealth and telemedicine as a mechanism to cope in this situation, and I think that is also one way to capture this information in real time.
I don't think we have time for any more questions, but I just wanted to thank our panelists so much for joining us tonight and sharing your wealth of knowledge and experiences with us. And I hope that this has been a useful and informative webinar for our audience. Thank you.
Thank you so much to Courtney for
Thanks,
moderating this webinar. And I want to maybe tell everyone that watch out for the next webinar in our series, which will be on food security and nutrition. So Bjorn had to leave early because he had a prior appointment. So we're missing him during the Q&A. But thank you so much again, and good night to everyone. Bye-bye.
Bye.